The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. This is Dr. Karen Luxford, Director of Patient-Based Care at the Clinical Excellence Commission here in Sydney, Australia. I'd like to welcome you to our webinar today, and very much to thank Juliana in the Office of ISQua in Dublin for helping us with the setup for this webinar, and to acknowledge CEC and ISQua as partners together in providing education through a regional approach. So ISQua is the International Society for Quality in Healthcare, and the CEC, the Clinical Excellence Commission here in New South Wales in Australia. And we're also very pleased to be able to provide this education to all, and specifically to our fellowship members for ISQua, and we know a number of you have joined us today. If you're not aware of the ISQua Fellowship, then pop onto the website and you'll see that there are some great opportunities available there for joining up to the fellowship. I'm going to introduce our speaker in a minute, but during the course of the webinar, if you would like to post questions to our speaker, please do that via the chat mode. You can type in your questions into the chat box. We'll monitor those questions, and then we'll have some time for question and answer towards the end. So today our speaker is Martin Laverty, who is the Chief Executive Officer of the Royal Flying Doctor Service of Australia. Martin has been recently appointed to this position, and in other roles he's the founding chair of Social Determinants of Health Alliance. He's also a member of the National Disability Insurance Agency Board and a member of the New South Wales Public Services Commission here in Australia. We very much look forward to hear what you have to say today, Martin. Martin's going to be talking to us about quality assurance and flying doctors, safety and aviation at a mile high. Over to you, Martin.
Karen, thank you, and can I commence by acknowledging the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land on which I'm standing today here in Melbourne. And thank you for the opportunity to talk about the Royal Flying Doctor Service. What I'm going to cover in our discussion this morning is first to look at the snapshot of health outcomes of the people that we serve in rural and remote Australia. I'm then going to talk briefly about the service role of the Royal Flying Doctor Service as a federated aeromedical charity here in Australia. I'll then get to the safety and quality agenda for the Royal Flying Doctor Service, and we see it through the lenses of aviation, through the lens of healthcare, and I'm going to focus on three specific unique areas of accountabilities, fatigue management, and patient handover as they relate to the Royal Flying Doctor Service, with our focus on both aviation and healthcare. I hope that this is an interesting discussion for you. To commence then, the community that we serve through the Royal Flying Doctor Service is unique. If you think about the size of the Australian continent, about 85% of Australia is classified as remote. It's this part of Australia that is the principal focus of our service delivery, but only about 4.5% of the population lives in remote Australia. So a small group of people spread over a very large area. We've traditionally worked in remote areas, country areas, but in more recent times, we've found ourselves working in regional centres and coming closer to the city as we become a charity that is responding to gaps in health service provision. The snapshot of health outcomes for people living in remote Australia doesn't tell a good story. There's a great disparity in life expectancy between those who live in the city and those who live in the Australian outback. In fact, there's a rough 2 and a bit year life expectancy difference between those who live in cities and those who live in regional and remote parts of Australia. If we look through the lens of child mortality, unfortunately, we don't have a good story to tell about survival rates of children living in very remote areas. In particular, the child death rate for Australian children born in very remote areas is 3 times worse than it is for those born in capital cities. There's a set of social circumstances, the social determinants greatly influence this health disparity, but there are also specific issues about access to healthcare services that underlie this particular disparity. If we look through the lens of mental health service utilisation, we can see that in a capital city roughly 7.6% of populations in capital cities are able to access MBS or medical benefit schedule funded mental health services. About half that amount, some 3% of people in remote areas access similar services. So we see only about half of people in remote parts of Australia accessing the mental health care that is otherwise available to those in city areas. All of these factors combine to say that the health needs of those living in country Australia are significant, and that there are differences in life expectancy and differences in quality of life of the communities the Royal Flying Doctor serves. So the service role that the RFDS plays is significant. First of all, we're an airline. We're in fact Australia's third largest airline after Qantas and Virgin. We have a fleet of some 67 aircraft, the Pilatus PC-12 or the Beechcraft King Air for those interested in the types of aircraft that we fly. They're a combination of single and twin engine aircraft. We use single pilots to fly those aircraft right around Australia. We have 1,300 staff spread across 22 bases, and each year we provide 282,000 patient contacts. And I'll speak as I work through this presentation as to what those patient contacts are. Our base network, the 22 bases spread across the country, gives us the assurance to those in remote and rural Australia that you are roughly 2 hours within a Royal Flying Doctor service being able to get to you in the event of an emergency. If a health need arises and you're in outback Australia, we can say roughly you're within about a 2-hour guarantee of being able to provide aeromedical assistance. We've just had our base network reviewed to test if the locations of them is an efficient fit to meet the service needs of country Australia. And we're quite confident that we've got Australia covered if you find yourself in the outback and you're in need of care. There's two primary services that we provide through our Aeromedical network across Australia. The first is to provide primary evacuation to those people that need urgent retrieval from a rural or remote part of Australia back into a more significant hospital for their treatment. The dots on the map of Australia that you're seeing are where the parts of activity of primary evacuation, actually occur. Now, if we look at the types of diagnosis that we are responding to through primary evacuation, this is a very busy chart, but to summarise it, it says roughly half of our primary evacuation is in response to injury or circulatory system diseases. So cardiovascular disease and injury, if you like, represents almost half of the primary evacuation activity that we undertook in the last financial year. If we then look at our second phase of aeromedical service, that's inter-hospital transfer, here you'll see that we are transferring people from parts of Australia into areas where there are hospitals able to provide that care. So you see the activity concentrated mostly around capital cities or major centres. That's a transfer from small medical facilities in parts of the country into larger medical facilities. And again, if you look at the types of diagnostic areas that we're covering, we actually see a reverse here. The bulk is circulatory system, and then secondary cause is that of injuries. So again, about half of our caseload in inter-hospital transfers through our aircraft are either circulatory system or injury. Now, the third area of our work is to provide remote area clinics. On this map of Australia, we're identifying where those clinics actually occur, and they're primary healthcare, GP clinics, if you like, where the doctors and medical teams fly in, deliver GP services, and then return to base. Now, in addition to GP services, we're increasingly providing dental care, mental health care, and eye care. The broader aspects of primary care for those that otherwise don't have immediate access to it because of the geography in which they live is the role of the Royal Flying Doctor Service to provide those services. Now, of course, delivering a remote area clinic happens in unique circumstances. So very often a clinic is delivered literally on a runway. It might be delivered in the shade of the aircraft wing. It will be delivered in someone's home, in a community facility, a hall, a school, very often out of the back of a truck. So these raise particular issues around how you assure safety and quality in the unique circumstances where these healthcare services are actually being delivered. So I'll now take us to the focus that we have within the RFDS on safety and quality. And that safety and quality focus has to base itself in both aviation and healthcare. And what I'd ask you to consider as I wander through the aspects of safety and quality for the Royal Flying Doctor Service is how aviation and healthcare have been intertwined to give us a unique set of healthcare standards that govern the way in which the Royal Flying Doctor Services delivers its healthcare. But for those in Australia in particular, you'll be familiar with the 10 National Safety and Quality Health Service standards that are now compulsory within acute hospitals, within day procedure units. They're not yet compulsory across primary care, and the Royal Flying Doctor Service is principally a primary care provider. So it's not mandatory for the Royal Flying Doctor Service to comply with the 10 Safety and Quality Health Service standards. But it's certainly the case that you can see in the work of the Royal Flying Doctor Service that we satisfy the principles, if not signing up to fulfilling all of the 10 standards. The RFDS certainly satisfies the 10 principles. Within our federated charity, we're a group of companies spread across the states and territories of Australia. We are on a pathway to actual accreditation against these standards. And in different parts of the country, we're at different levels of actually meeting formal accreditation against these 10 standards. But these 10 standards are certainly a base for the work that the RFDS undertakes. Now, if I can take you out of healthcare for a moment and instead go to aviation, there's a set of standards that governs the way in which aviation services are delivered themselves. I'm sharing with you here the aviation safety management systems that are in place within the Royal Flying Doctor Service. And there's a great similarity with the way in which the safety and quality standards are designed and the way in which the aviation management systems are designed to govern the safety of aircraft. So there's an articulation of what the safety and policy objectives should be. There's a focus on safety risk management, on safety assurance, and indeed safety promotion. Very similar themes to safety and quality in healthcare underpin the way in which safety and quality in aviation is ensured as well. For the Royal Flying Doctor Service, which is both a healthcare provider and an aviation service provider, over the recent years, the Flying Doctor Service has actually brought these two schools of thought together and has created its own set of safety and quality standards that bridge both aviation and healthcare together. Now, this set of standards is unique to the Royal Flying Doctor Service, and it actually has informed the way in which aeromedical safety, both in Australia and I would say internationally, has been influenced in recent years. The national standards for aeromedical evacuation have been designed by the Royal Flying Doctor Service. They are public documents and they're available on our website. And as you can see, a bit like the safety and quality standards for healthcare, a bit like the aviation standards laid out, the Royal Flying Doctor Service's own standards set out the elements that are necessary for proper provision of safe and good quality aviation and aeromedical services. So we focus on the provision of care to patients. We place significant importance on the role of communication between flight, medical, nursing and allied healthcare professionals. The role of coordination of the components of both the flight and the healthcare service are central. We talk about how to determine priority, how we will task a decision to send out a flight crew to a particular part of Australia as opposed to not responding to another circumstance is key. We then also talk about elements of safety within the aircraft, the type of equipment that's required, and the documentation that must underpin all of these services. Now, rather than go through all of the aeromedical evacuation standards in detail, what I will do briefly is provide some abstracts or an illustration as to how some of these components work so that you can appreciate how we've blended aero and medical into our own aeromedical evacuation standards. So the illustration I'm going to draw down on is how we determine priority in response to a call that will come in for an evacuation. And you'll see that the standards set out a number of headings to determine what is a priority, so that we know that when there is a potentially life-threatening circumstance, that gets the urgency that it would warrant. And both the flight team, the medical team, the allied healthcare team, when the call comes into the Royal Flying Doctor Service, can determine the availability of resources to respond to the urgency that's presented by referring back to the standard on which each of our staff have been trained and are very familiar in how to deploy. That standard in organising priority of tasking has some further detail and the considerations that we take into mind. The priority of the case, the actual crew that is available for the selected transfer of the patient. The crew, the medical crew, must fit the needs of the patient's circumstances. And of course, that's mostly determined by remote control, because you might have a call that comes in from a country area where a family member or a work colleague is reporting they're not a medical professional themselves, they're describing what the circumstance is, and the flying doctors needs to work out what type of clinical priority needs to be allocated against the availability of information. Now, operational considerations are taken into account. So the restriction on any cabin altitude is relevant, and whether or not that particular aircraft has another patient on that flight or another patient intended to be on that flight. The way in which our aircraft are configured, they have capacity for upwards of 2 patients to be transported at a time. That's to deal with the efficiency of sending out aircraft, but it's also then a consideration as to if a patient already on board an aircraft is suited to another patient joining that particular flight. Consideration is given to what special equipment, drugs or blood products will be required, whether patient handover is to occur on an airport, at a hospital, and importantly, it's considered as to who made the decisions. Were these clinical decisions of a long experienced doctor or nurse, or were they decisions that out of circumstance were necessarily being advised by other people? All of these come together to determine whether or not the priority will be awarded according to whatever circumstances presented. Within the standards, there's an articulation of the minimum equipment that needs to be provided on the plane, and there's a specific requirement that that minimum equipment is constantly kept up to date, checked for continued reliability, and when at end of life replaced. This is similar to the way in which surgeries within hospitals manage their retinue of medical equipment. We too ensure minimum equipment for our aircraft, but obviously the equipment list is designed specifically to respond to the variability in the types of medical services that our health professionals provide. Now, I'm going to here give a specific diagnostic illustration, and I've drawn down on an extract from our Western Operations Clinical Manual to outline the type of thinking that's been put into how to respond to a specific diagnostic request. Here I'm giving the illustration of eclampsia, so that there are considerations that the flight crew, the medical and nursing team make before the flight is dispatched, if it's in response to preeclampsia or eclampsia. And then there's considerations that the medical and nursing and flight crew give in flight. So this notion of planning for what is expected before the aircraft departs the base, and then indeed the type of management for the particular diagnostic category whilst the flight is underway. This notion of planning before and attending to circumstances during gives the capacity for the medical and nursing team to be able to respond to the eventualities that might occur when in air, because there isn't the opportunity to make referral to another part of a hospital when you're actually up in the air. All of the attendant patient needs have to be addressed physically in the aircraft. Therefore, substantial work has gone into drawing up a very extensive clinical manual that addresses different diagnostic categories, this being the illustration of eclampsia, that allows the medical team, nursing team to prepare before flight and respond during flight. Now, most importantly, this clinical manual relies on the peer-reviewed evidence. It's constantly updated when new information becomes available, but it's also been honed after years of experience of very capable clinicians. Aeromedical work, and indeed working in rural areas, is a specialty in and of itself. And our clinical manual is actually a product of many years of expertise being contributed to by many clinicians across the country to inform the way in which aeromedical services are operated by the Royal Flying Doctor Service. In seeking to wrap up and bring this focus on clinical safety to some type of conclusion for you, I'm going to draw out 3 specific illustrations as to how aviation is influencing the way, or could influence the way, in which healthcare standards generally in acute hospitals and other parts of the healthcare system might be relevant. This link between aviation informing safety and quality in healthcare, I think, is a curious one. The first is that of accountabilities. Those of us that are familiar with the inquiry into incidents at the Mid-Staffordshire Trust in the United Kingdom will recall that that inquiry said clinicians need to be held properly accountable for what they do to their patients. The Canadian Patient Safety Institute said that teamwork and communication failures are often the leading causes of patient safety incidents in healthcare. Peer-reviewed studies have said that despite the attention on healthcare service failures internationally, there's been little focus in the literature on this notion of clinician accountability to inform how accountabilities can be improved to enhance patient safety and quality. Well, in aviation standards, accountabilities are key. So if we turn to the civil aviation regulations in Australia, it's the pilot upon whom specific accountabilities are placed. So before flight, the pilot is singularly responsible for ensuring the safety of the aircraft, for ensuring the aircraft has all that it's going to need to be equipped with for the flight, particularly reliance on fuel. It needs the pilot needs to assure that all air traffic control instructions have been complied with. And most importantly, the pilot is responsible for ensuring that all operating and other crew members on board are in a fit and proper state to perform their duties. For the Royal Flying Doctor Service, the pilot therefore has a responsibility to ensure that all of the flight crew who are on board are in a fit and proper state to perform their duties. I'll ask the question, in healthcare, is there someone singularly in charge and accountable for ensuring that all are in a fit and proper state to perform their duties? During flight, similarly, the pilot is in command, and the civil aviation regulations make it very clear that there is one person ultimately accountable and ultimately responsible for the start of the flight, the operation of the flight, and all that occurs within it. And there's strict criminal responsibilities should the pilot not comply with elements of those accountabilities. Now, again, the pilot is responsible during the flight for the conduct and safety of members of the crew and aircraft. And I'm drawing here the link to say, who is it within the healthcare system that has that singular accountability in the same way that a pilot does around ensuring the safety of all that goes on both before and during that flight? It's perhaps a lesson that as we think through safety, quality and accountabilities in healthcare, about considering this notion of single points of accountability for ensuring the safety and quality of all that's undertaken within a healthcare service. I'll turn to my second illustration, and that's how we manage fatigue management in aviation. I think fatigue in acute hospitals, particularly in emergency departments, takes on almost an element of folklore. So we know from the peer-reviewed studies that fatigue has been identified as affecting the cognitive ability of health workers to make clinical decisions. We know from some simulation studies that fatigued surgeons lose effectiveness when they aren't properly managing their own personal circumstances of fatigue. And again, we see peer-reviewed studies that say very often clinicians within particularly acute hospitals are themselves perhaps unaware of their own fatigue and are perhaps unaware of the impact of that fatigue on their clinical outputs, raising questions around how we properly manage safety and quality and its interaction with fatigue. Well, if we draw from the experience of aviation, within the way in which a pilot prepares for flight, it's very clear how a pilot is expected to manage their own personal fatigue. So within the Royal Flying Doctor Service, I'm now drawing on an illustration from our Central Operations Flight Risk Assessment Matrix. The pilot has to conduct an assessment of their physical symptoms, their mental symptoms, and their emotional symptoms, and give themselves a score to attest for whether or not they are capable or too fatigued to undertake the flight. And it's not just fatigue that is considered before that decision to take off can be affirmed. Again, using our Royal Flying Doctor Service pre-flight assessment, the pilot's own self-assessment of fatigue is just one element that then comes into other considerations. We consider whether or not the flight is occurring at night or during the day. We consider how long the pilot's been employed. We consider whether or not there's likely to be weather impacting the safety of the flight before it's actually dispatched. We consider, is it a mercy flight? Is it required to make an emergency? Is it likely to make an emergency landing because of the urgency of the particular patient's clinical circumstance on board the aircraft? Now, this might seem unusual, but because of where the Royal Flying Doctor Service regularly has to land its aircraft, it gives consideration as to if there is a vermin risk in the aircraft landing at a remote area airport. The way in which the Royal Flying Doctor Service swoops into and then scoops up a patient in some parts of Australia means that they're often landing on runways that are not used regularly, that very often have kangaroos or emus roaming on them that need to be cleared off. All of these considerations need to be thought through before the plane can put itself down safely. These considerations are then put together. Assessment is made as to if it is safe for the flight to proceed, and if it's safe, the flight takes off. If it's not safe, alternate pilot or alternate arrangements need to be made. Again, I'll ask the question, within provision of clinical services in our emergency departments and in our surgeries in hospitals, do we manage fatigue and other considerations of risk? Perhaps not immediately related to the technical ability of the healthcare team to deliver the service, but are we thinking about fatigue properly as part of safety and quality? The third and final illustration that I'll share with you is that of patient handover. Now, we know that hospitals are working on improving their practices of patient handover. The National Safety and Quality Standards in Australia are actually driving attention about patient safety through that notion of a safe handover. We're yet to see a peer-reviewed study since the introduction of the Safety and Quality Standards in Australia look in a systematic way at improvements in handover within acute hospitals as a result of the standards being introduced. But we certainly know that the better the handover, the better the passing over of information and the role for the patient themselves to have that informal role in that patient handover, the better likelihood of there being successful safety and quality outcomes. Now, if I can put it to you that the circumstance in which patient handover occurs for the Royal Flying Doctor Service is a little different from patient handover within an acute hospital. Very often we receive information about the patient over the distance, over the phone or radio from someone who's not necessarily a health professional. We send out an aircraft to retrieve that patient without full understanding of the circumstances. On arrival, that patient handover occurs in very unique circumstances. We've in fact tracked the patient handover cycle, and we see that there's upwards of about 7 different handover points that just the Royal Flying Doctor Service is involved in. That initial contact, the decision to prioritise the dispatch of an aircraft, the preparation and the selection of the team that is actually dispatched, the actual patient retrieval, the in-flight care, the return of the aircraft to the airport, and then finally the patient transfer into the healthcare service or the hospital. Those 7 different points of patient handover, all uniquely different from the way in which patient handover occurs in an acute setting. The standards that the Royal Flying Doctor Service has in place have been designed for that unique difference in the way in which patient handover occurs for the Royal Flying Doctor Service, but it certainly points to the importance of ensuring all of that works smoothly. If we then think about the way in which we operate our remote consultations, and it's at this point that I will seek to bring my discussion to its inevitable conclusion, we provide upwards of 225 daily remote GP services, remote nursing services over the phone, over the radio. So people who live in far-flung parts of Australia who have a patient relationship with the Royal Flying Doctor Service ring in and receive a general practitioner's consultation over the phone. Now, telehealth is not new, but the difference between the Royal Flying Doctor Service's telehealth is that there isn't really the opportunity to say, well, just pop down to the chemist or just pop down to the emergency department or call in to the doctor's surgery. All of the diagnostic and treatment, as is clinically appropriate, is literally done over the phone. That creates a unique circumstance and calls on the capability of the clinician to be very skilled and to use the inquiring techniques over the phone of working out the diagnostic for the particular patient. Now, in some parts of Australia, there's what we have called medical chests. That is a large box that has 90 different pharmaceuticals available within it for the person who's been diagnosed over the phone to receive their prescription. Again, we're relying on the patient to go to the medical chest, to take the medication, and to utilise it properly. Now, there's a set of governance standards around who is suited to having a medical chest, where they're located, how they're managed. Training, an online training module is necessary as part of the allocation of those medical chests in some parts of Australia. So this raises a whole set of unique circumstances around patient safety and quality. When you're diagnosing over the phone and then prescribing through a medical chest without the pharmacist and without the general practitioner actually having face-to-face time with the individual patient. So to conclude, the future for the safety and quality agenda within the Royal Flying Doctor Service, well, we're on a path towards accreditation against national standards within the Royal Flying Doctor Service, noting that we're already operating to our own unique aeromedical standards that have evolved out of both use of peer-reviewed evidence and our own clinical practice over many years. We're looking at moving to better health outcome reporting, knowing that we need to focus in talking to our patients and our publics around the patient experience and their health outcome. We're looking to see how we can expand our role in aeromedical nursing allied health training. We need to ensure there is a health workforce profession skilled in both rural and aeromedical services for the years ahead. We know at the moment there's a possible review of fatigue rules as they apply to medical professionals working within aircraft. At the moment, strict fatigue rules only apply to our pilots. There is consideration of them being expanded across our medical and nursing teams, and that would have significant impact on the way in which we utilise our health workforce. And of course, we're focused on continuous air safety improvements as part of the bread and butter of running Australia's third largest airline. So I hope that this very quick overview of the health of rural and remote Australians, of the services that the Royal Flying Doctor Services provides to them, and indeed that snapshot on safety and quality considerations in both aeromedical and aviation has been useful. And I'll now invite Karen to join me again and be very welcome to take any of your questions.
Thank you very much, Martin. It's Karen Luxford here. There's some questions that I wanted to pose to you. That was a marvellous presentation, thank you, and gives us a great insight to a fantastic service. One of the questions relates to the number of patients on board. So you mentioned, I think, typically one patient at a time, but occasionally you may have more. Can you elaborate on that?
So the aircraft are mostly equipped to accommodate upwards of 2 patients and medical nursing teams and family members or carers. So a typical flight might be a dispatch for an aeromedical retrieval of a person who's been injured, and if there is no other call on that particular flight path for the collection of another patient, you would expect that that particular patient would travel alone. There are circumstances, because of the desire to efficiently utilise this aeromedical infrastructure, to pick up one patient and then collect a second if it makes logistical sense to follow a particular flight path to do so. But there's a set of clinical considerations that drive that decision to put 2 patients on the same flight. The first is the nature of the diagnosis of the 2 patients. Is it compatible to have those 2 patients on the same aircraft at the same time? The second is the capacity of the actual flight crew. Do we have a doctor nurse? Do we have a flight nurse on his or her own? Or are there other clinical considerations as to the capacity of the actual flight team to be able to deal with 1 or 2 patients? The third consideration is a straight logistical one. Where are the patients individually heading to? So that if you think that the role of the Royal Flying Doctor Service is to retrieve or to transfer between healthcare facilities, all of those considerations are taken into account. But most importantly, these considerations are documented. They're determined in our standards so that there is a consistent decision-making tool for the tasking and medical and nursing teams to actually utilise. There's then practical consideration given to resource availability at the time, and above all, that clinical decision-making overrides any of the other considerations. So safety and quality in these circumstances comes first.
Thank you. And also, Martin, is this a unique service internationally? I'm thinking about other countries with vast distances. Are you familiar with other services in other countries?
It's unique to the extent that Australia was first. It's unique that Australia has an extraordinarily large footprint with small populations in it, that the Royal Flying Doctor Service has literally itself had to create the healthcare standards with that merging with aviation standards to ensure the safety of our patient service. In recent years, recent decades, we've certainly seen the establishment of services in New Zealand, in Canada, and the Swiss use a similar type of service given the, whilst a small country, but unique terrain of Switzerland, but they have a perhaps slightly different reliance on helicopter as opposed to our fixed-wing aircraft. Within Australia, there are other variations of aeromedical services as well, but it's certainly the case that the uniqueness of the Royal Flying Doctor Service of having established this notion of aeromedical services into remote areas, of developing the standards of healthcare that actually govern safety and quality, and now that extraordinary infrastructure across Australia, that 22 base network spread across Australia, being able to offer that indication of that average 2-hour response time to remote parts of Australia certainly puts us in a unique position internationally to guarantee that coverage across such a large continent. I'll just indicate
sorry, Martin, I was muted. I'll just repeat that. In the situation where you talked about possibly being up to 2 hours away as a service. What do you do if it's a life-threatening situation? You talked about GP consults over the phone, but what is your capacity for giving directions in relation to life-threatening situations when you can't make it physically there in the 2 hours?
Thank you, Karen, and that's a central point to the way in which the service operates, and again, it's part of the uniqueness. So we have within each of the bases the capacity for the doctor or the nurse, whichever is clinically appropriate, to take the call from the bedside or the accident itself to speak directly to either the injured or ill or the person that might be phoning in the actual incident. It's very often the case that the doctor who receives the call is the doctor who will talk through the immediate management of the circumstance, who can remain in contact with the person at the injury or the side of the person who is ill. During flight, we're lucky and fortunate now that our communications are such that both radio and mobile contact allows that ability to talk whilst in flight to the particular arrival or destination point. And that doctor can very often be the same person that will be treating the patient, having guided from the time the call is received through to the person being transferred or handed over to the acute healthcare service. So that if you think about that unique 7-point handover process that I referred to, it can very often be the doctor who receives the call, who will provide immediate advice. And that advice, we shouldn't underestimate the benefit of rural area experience. Many of the clinicians that work within our service have come up through learning through practical experience in country areas how to provide over the phone or over radio advice for the immediate management. It becomes a skill set about how to encourage someone that might not be a health professional in a very difficult circumstance to care for themselves or to care for someone who's injured or ill. And that continuity of the doctor taking the call, being on the flight, being involved in the retrieval, and then being with the patient until the handover at the acute healthcare service. All of that is a unique part of the way in which the Royal Flying Doctor Service delivers its care, and it actually distinguishes telehealth or remote consultations that the Royal Flying Doctor Service does from other types of call centre type telehealth services, that where you might ring a generic telehealth service and be perhaps triaged into another part of the healthcare service. In the Royal Flying Doctor Service's case, the doctor takes the call, the doctor is probably going to be the same person providing the care. And that's a unique part of the quality and safety guarantee that the Royal Flying Doctor Service is able to offer.
Thank you, Martin. We have a number of questions coming in now. I'm not sure we'll have time to cover all of them, but we have a question about the increased governance. Given that the service started in the 1920s, quite some time ago, do you know what was that driving stimulus for that improvement in governance? And I appreciate this is going back in history.
Well, the origins, a fellow, John Flynn, was the founder of the Royal Flying Doctor Service. He was providing a response to identified healthcare need in parts of country Australia. And before aeroplanes, there was actual use of camels to retrieve patients and ship them around parts of country Australia. We've come a long way. As aviation standards, so put healthcare to the side for a moment, as aviation standards have improved, we've got an extraordinary confidence now about the safety of aviation within Australia internationally. We can have a confidence that the engineering standards, the maintenance standards, the way in which we train our flight professionals and keep their training current, that similarly has been informing healthcare. And if you like, I think we could say that in the Royal Flying Doctor Service, there is that element of the chain of command where the pilot is by regulation required to be responsible for what happens on the flight. We actually see a greater clinician adherence, anecdotally, to clinical standards within the Royal Flying Doctor Service because of the culture of the chain of command and that central importance of safety in aviation influencing clinical governance. Now, that's not something that you might expect, but without wanting at all to be critical of my colleagues working in acute hospitals, we know that clinicians, very capable and talented people, don't always easily follow their rules and expectations. In the Royal Flying Doctor Service, we see a greater propensity, because of the influence of aviation's principle of chain of command, on standards adherence. So it's actually been relatively easy for the clinical governance of the Royal Flying Doctor Service to grow and enhance, because it's already been required because of the governance of safety of aviation. And those two have come together in a unique way. So when a flight team sets off, there isn't a medical and there isn't a flight team, there is a Royal Flying Doctor Service team on board. It comprises pilots, nurses, doctors and allied health professionals, and they all work to this common standard of safety and quality. And we think it gives it a unique perspective into how to guarantee safety and quality through that quite unusual governance arrangement.
Thanks very much, Martin. We actually have a flood of questions coming in at this point, so I'll try just to pick some of those. I think you've raised a point that one of our questions is talking about. We had a question about the fact that some doctors in health services are getting a little bit fed up with that comparison of aviation and healthcare, because in health services often people say, well, we're different. But it sounds to me like what you're saying is there are many similarities, and some of that accountability is what really helps to improve your safety and quality. Is that correct?
So what I wouldn't say is that you can simply pick up aviation and overlay against healthcare. That would be a naive argument to be making. But where we've seen these two schools of thought, aviation and healthcare, through the circumstances of the Royal Flying Doctor Service combined together, it's created this unique set of standards, this unique requirement of the aviation and the healthcare teams to coordinate their service, to communicate, so that the way in which a doctor or a nurse communicates the clinical urgency of a patient's circumstance to the pilot is central, because it's then the pilot that communicates to the air traffic control to determine whether or not they will be given a priority landing when they're coming into an airport. Those of us that have sat in air congestion and circled around any of our major airports anywhere around the world know that a flight doesn't always run on time. If you have someone on board who is ill, injured and needs that aircraft to land, the pilot and the medical team need to be able to communicate sufficiently in order for the pilot to make a decision about the urgency of the landing, and then in turn communicate that to air traffic control, who have no understanding of clinical, medical or nursing needs. So that unique set of circumstances, I think, has told us that aviation standards have influenced the way in which our medical teams need to work and vice versa. And it's created that unique circumstance where we see that anecdotal greater adherence to clinical standards because of the importance of this principle of chain of command, of there being one person in charge and that one person being responsible for what happens on the aircraft whilst it's in the air.
And Martin, just one further question and then a comment to close with. One of the attendees on the webinar has asked a question about follow-up on the outcomes of patients. Given that you're often delivering them to other services, what responsibility do you have and what do you do about following up on the ultimate outcomes for patients?
Well, there's two perspectives to that. So that our primary evacuation, our inter-hospital transfer, the outcome very clearly there is to ensure the safe arrival and the avoidance of clinical deterioration of the patient from the moment of retrieval to the moment of presentation at the healthcare service. So the outcome is the safe transfer. But there's an entirely separate part of the service provision of the Royal Flying Doctor Service. That's in our dental care, it's in our mental healthcare services. It's in our eye care. It's in our primary healthcare services, be they the GP clinics, of which today and every other day there'll be 45 clinics happening right around the country, or our telehealth or over-the-phone consultations. Those types of areas actually establish a patient relationship. Not all of the patients are continuous patients, but very often someone taking an over-the-phone consultation, or someone who visits a remote area clinic, or who's been cared for through one of our mental health, our dental health, or our eye care programs, that does provide the opportunity for a greater continuity of care. And there we're looking for the same type of healthcare outcomes as you would expect in any primary healthcare service where there is a continuity of patient contact. So with those two different perspectives, the safe transfer and the avoidance of clinical deterioration, where the objective is to transfer from A to B, but then that opportunity for charting the health outcomes when you have a patient who is in a longer relationship through the mode of primary care delivery.
Thank you, Martin. And just in closing, there's been an offer by Dr. Andrew Berry to perhaps collaborate in relation to revision and development of the Aeromedical standards. I think Andrew is involved in child flight, so that might be something for connecting the two of you in the future. So I would like to draw this webinar to a close. We've had many questions, and I'll try also to get some of those to you, Martin, after the fact. But we wanted to thank you very much for your time today, for a fantastic presentation and such a wonderful insight into a marvellous service for Australians in rural and remote areas, and I'm sure many lessons for our international colleagues who have joined us today. So thank you again for your time, and please everybody make sure that you keep in touch with the ISQua website and with our regional activities between ISQua and CC, and we look forward to you joining us again. Thank you.
Thanks, Karen.